Abhishek, who is answering today?
सर बताया नहीं सर, मैडम से बात हुई थी. I mean, बताया नहीं सर, मतलब.
Sir, I am answering today.
Okay. Who else?
Good evening, sir.
Good evening.
Good evening.
Because in the first case we will have multiple cases. So I want at least 3 or 4 of you.
So sir, if nobody is answering, I'll answer, sir.
Abhishek, you are there, na?
Yes, sir, I'm there.
Yeah, you answer, but I want another 2 also later on. So just
No problem,
find out.
sir.
Huh?
Okay, sir.
Or
Okay, sir.
just or someone, you can ask them. We can unmute
Okay,
them.
sir.
And
Okay, sir.
Ojas is there?
Ojas has
Ojas
not yet
has
joined
not
in, sir.
joined yet, sir.
Okay, okay. You just ask him. Okay.
Right, sir.
Ojas has joined.
Good evening, Gite sir, Gaurang Shah, sir.
Yes, good evening. Ganesh has joined. Ganesh, I think Ganesh and one is Dr. Bakshi.
No, not joined, sir.
No.
No.
We just wait for 5 minutes, 7 minutes, and then I'll tell Dr. Bakshi to. I already messaged him. Not Ganesh Bakshi.
We will initially go ahead with one case, and later on there are multiple situations, na?
Correct.
Okay.
Hemang, see, we had that presentation in West Zone where we had, Dr. Hemang Bakshi had multiple cases with the questions, okay, what to do in these cases. And at the end, I had conducted rapid fire, like 5-6 different cases scenarios. So total, we had about 10 cases. So all are different cases and they are very good cases. So it will be a, good number of cases, different types, what to do, multiple scenarios.
In spite of
Hemang has got that presentation. So he will, I have told him to do it for, last 1 hour.
Okay.
So Mahendra,
in spite of discussing
Mahendra,
the
first,
history. Yes, sir.
First one, like 45 minutes, we can discuss one case. And later on, Hemang Bakshi will, you were there in West Zone?
No, sir, I did not come.
So last day we had that T1A, T1B, and T2, multiple case scenarios, like what to do in such
that
case.
will be good, sir. That will be good.
So at the end, and you can, every time you can give your special comment at the end,
No,
like
sir,
students are answering.
What is special,
So
sir?
you and Ganesh can answer,
Yeah.
what are to be done.
Sure, sir. Yeah. Okay. Yeah.
So first we'll discuss one case and then we'll go ahead with that.
Okay, sir.
Yeah. Unmute Dr. Hudedar.
Abhishek, when will be the practical exam? Tentative?
Sir, good evening, sir. They have given a tentative date of October and November, sir. So I think before November it should be over, sir.
Okay. So, do you want any change in the classes, pattern of classes taking where? As the exam is nearby?
Abhishek, just ask your friends because we have already done OSCE. If anything else extra you want, do you want instruments or anything? Just let us know.
So
So
instruments
next
should be better, sir.
couple of classes we can have that.
Another thing
Or
is,
just you can also
So we can take instruments and specimens.
another thing is one more table Viva nowadays that is of subspecialty, in which the recent advances and subspecialty plus the type of research and whatever the presentation or you have done during your 3-year tenure, that will be for near about 10-20 marks का रहेगा वो एक table ऐसा कुछ.
Gite sir, do they ask about robotic instrument also nowadays?
रोबोटिक प्रैक्टिकल में आता है, इंस्ट्रूमेंट तो वहाँ कोई रहेगा नहीं ना. यूजुअली जहाँ रोबोट का सेंटर है वहाँ पे अगर एग्जाम रहे तो पूछ सकते हैं, लेकिन यूजुअली रोबोट का प्रैक्टिकल ट्रीटमेंट में ही आ जाता है.
ओके.
रिसेंट एडवांसेस के टेबल पे सब स्पेशलिटी में ट्रांसप्लांट यानी आगे ना रोबोटिक लेजर कुछ भी पूछ सकते हैं उनके दिमाग में जो आएगा.
ओके सर, जस्ट क्वेरी आई.
इंस्ट्रूमेंट में तो नहीं पूछेंगे, लेकिन सब स्पेशलिटी और ये टेबल वावा जो है रिसेंट एडवांसेस तो उसमें पूछ सकते.
ओके सर, ओके, थैंक यू सर.
Mahendra, can you just ask Dr. Ganesh Bakshi when he's joining? And I
Sir,
will request.
Sir,
Pardon?
let me call him. Sir, he is joining in few minutes.
Okay. It is just for I am asking for opinion of the students. Should we start like debates in between the two students, like on small topic like T1 G3? Two people will or one people will talk on early radical cystectomy and one will talk on the QRBT. Like upper ureteric stone, one will talk on RRS and one will talk on pushback PCNL. with 2-minute expert comment.
Okay, sir. Yes,
Sir,
sir.
I
Yes,
think
sir.
it's a very good suggestion, sir.
Yes, sir.
Yes, sir.
Yes, sir.
तो 5 मिनट का रहेगा वो यूजुअली 5 मिनट एक ने बात करना है, 5 मिनट दूसरा बात करेगा, तो उसके ऊपर 2 मिनट का कोई भी एक्सपर्ट जो भी वो एरिया में अच्छा काम करते है उससे अपने एक्सपर्ट ओपिनियन देने के लिए बोलेंगे.
Okay, sir.
अगर आप
Yes.
सब चाहते हैं तो दैट विल बी द वेलकम चेंज हो सकता है.
Yes, sir.
Yes, sir.
गुड इवनिंग सर, बख्शी सर.
गुड इवनिंग. सॉरी है, थोड़ा
पंकज
हिंदू
sir, good
जाति
evening.
कॉल ले रहा था तो
Good evening. Good evening, everyone.
गुड इवनिंग.
Good evening, sir.
Good
Good
evening, sir.
evening, Pankaj sir. Good evening, Ganesh sir.
Good evening,
Good evening,
Ganesh. Good
Mahendra.
evening, Pankaj.
Good evening, sir.
Paras has not yet joined. Once Paras join, we'll start
Okay.
the class.
So, Gaurang bhai, before we start, let me share one very, very interesting anecdote with you.
Yeah.
I was at Delhi for Percon.
Huh.
And in this Percon, there were around 700 delegates, of which at least 400 were immediate pass people.
Okay.
Okay, minimum 15 to 20 people came and spoke to me and spoke very highly about your classes.
And no, sir, it is our
Our.
classes.
नहीं
It is
देखो
our.
पूरा जो लीड लिया है वो तो गौरंग शाह साहब ने लिया है. हम तो साथ में सपोर्टिंग रोल है. खैर आपका रोल बड़ा है पर हमारा तो बहुत सपोर्टिंग रोल है.
नहीं,
पर
sir.
कम से कम 15 लोग कि हम पास ये क्लास की वजह से हुए. That's a
नहीं,
big thing to say.
Sir, that is combined.
there are places where Ganesh and you means your expertise has really see I am doing more of the like collecting the cases and presenting and all these things, but when the final thing comes, I think Mahendra, Ganesh, you, and of course Gite is continuously there, but then there are other faculties which are coming. So we should find out some more innovation, so which is more helpful to both DNB as well as MCH.
One of the students from South, he met me and he spoke to me about एक बार मैंने कभी तो भी एक presentation लिया था non-invasive urodynamics के ऊपर.
Okay.
So interestingly, he said in his exam he got asked on that, and examiner was extremely impressed. So he specifically came to thank me. मतलब मुझे इतना अच्छा लगा कि कम से कम 15 लोग, और ये सब ऐसे लोग हैं सब जिनको हम जानते नहीं है. मैक्सिमम लोग अपना कैमरा बंद रखते हैं तो हमने उनका चेहरा कभी देखा नहीं है.
And we are dedicated. Every Tuesday, all of you for 1.5 to 2 hours, you are keeping free for them. I think.
No, and I think you see everybody has played a role. The way Tanvi is updating all the videos on the YouTube channel. I think people are regularly watching the YouTube channel before their practical exams.
Lots of people are watching.
Yes.
1,000 subscriber now.
Yeah.
Great.
And many people like to revisit and revise probably.
Absolutely.
I think COVID में सब change हो गया है. People have from book revision to YouTube revision.
Correct.
पर मुझे बहुत अच्छा लगा साहब, यानी मैंने
When they get all the points at one go.
एक छोटा एफर्ट इतना बड़ा इम्पैक्ट कर सकता है, सोचा नहीं था कभी.
Yeah, and that was all by Archan and Tanvi. Mainly Archan. Archan, told Tanvi, please tell Dr. Gaurang Shah to start on Zoom. And that was basically to start for Mumbai students who are attending our classes. And then everyone liked it, and today people are watching even on YouTube. That is I think remarkable.
Absolutely. I was extremely happy.
I'll just find out why Paras has not joined.
हेलो. हाँ सर.
ज्वाइन किया ना?
हाँ मैं ज्वाइन किया था, वो पर मुझे म्यूट कर रखा है हम लोगों ने.
ओके. अरे पारस को अनम्यूट करो. मेक पारस को होस्ट. Okay. Paras, you can start.
Hello.
So Pankaj bhai, today we have got 45-50 minutes of one case presentation, and then in apna Nasik conference. You remember last day we had T1A, T2 multiple case discussion. So we will keep it so that multiple cases for students.
Sure.
Hello.
Okay.
Hello.
Yeah. So 3 people are answering. I think Ojas is there, Yasir is
Hello.
there, and Abhishek. Correct?
Yes, sir.
Yes, sir.
Okay. So you have Ganesh Bakshi, Mahendra again, Gite sir,
Abhishek sir, can you
and
hear me? Hello.
Yes, I can hear you,
Yes.
Paras.
okay, fine. Okay. Paras, go ahead.
So presenting a case of a 60-year-old gentleman, shopkeeper, resident of Mumbai, presented to us with the chief complaint of left flank pain since 3 days. Hello.
Yes, tell me.
Yes, Abhishek.
Yes, sir. So I want to elaborate on the history of the flank pain, sir. The onset, duration, and progress of the pain. What is the character of the pain, sir? Severity of the pain, radiating or non-radiating, whether it is relieved by medications or not, and whether there are any associated features associated with the pain or not, any lower unit tract symptoms, any hematuria associated, any fever associated with the flank pain or not, any previous history of any surgical instrumentation or any surgeries done in the past, any previous history of similar pain that has occurred in the past, and yes, sir, comorbidities, diabetes, hypertension, I want to ask, and yes, sir.
वो भी पूछना चाहिए ना, history of hematuria with pain, history of
Yes, sir. Associated features I asked, sir. History of fever, history of hematuria, history of lower unit tract symptoms, and history of any previous similar complaints in the past, sir.
Okay.
Associated history में.
ठीक है.
Trauma. Trauma also.
Trauma, correct.
Right. Okay.
Trauma.
Okay. Sir. Okay.
History was given by patient himself and seemed to be reliable. According to patient, he was apparently asymptomatic 3 days back when he developed pain in left flank, sudden in onset, progressive, colicky in nature, associated with nausea and vomiting, radiating from loin to groin, partially relieved by medication, and there is no such episode in past. There is no history of fever, burning maturation, lower urinary tract symptoms, hematuria, recurrent UTI, urethral instrumentation or surgery in past, no bleeding disorder, anticoagulant therapy or blood transfusion, no lithuria or trauma, no facial puffiness, pedal edema, breathlessness, jaundice, headache, and backache. Patient is known hypertensive and is on medication. There is no other comorbidities. There is no history of any surgical intervention in past. Patient is mixed by diet, no allergy to any food or drug, no addiction to any form of tobacco or alcohol intake. Family history is nothing contributory.
Okay, so clinical, any diagnosis?
Sir, 60-year-old gentleman left flank pain since only 3 days, sir. So first differential diagnosis I would think of is sir, stone disease. Second can be, sir, it is not associated with any other feature, sir. So and colicky pain. So I think
Stone disease only.
disease. Yes,
Stone
sir.
disease,
And
yes, sir.
We
What
don't have
other-
anything suggestive of any
probably
or anything.
no, sir, no previous such history.
Only one history can mimic is clot colic, but there is no
Clot
hematuria.
colic?
So clot
Hematuria.
colic
Yes,
cannot be put together for a diagnosis.
Sir, PUJ obstruction, hydronephrosis. I'm not sure, sir, whether to mention or not.
I don't know, colicky pain 60-year-old में आएगा कि नहीं? PUJ obstruction,
Yes.
yeah,
60
we'll have a
Yes, sir.
aching pain rather than colicky pain,
Yes, sir. Yes.
Yes, sir.
if at all. Otherwise, no pain also.
Yes, sir.
So if we have to think very, means the first diagnosis will be urolithiasis, probably a ureteric stone presenting with colic. Second could be maybe a cystic disease.
A cystic disease, complication of cystic disease, a hemorrhage maybe in a
Yes.
cystic
So
disease or
I would
infection.
that clinically, let's stick to these two diagnoses.
Right, sir.
So, what other factors other than Kolki pain that is favoring with the stone disease?
Associated nausea and vomiting.
Sir, nausea, vomiting, sudden history, sir, 3 days, and radiating from loin to groin, and partially
Yeah.
relieved by medication, sir.
Fine. Radiation also is one important.
Yes, sir. Yes.
Of the pain.
Yes.
Fine.
Can you make out the site of the stone based on radiation?
Sir, it is radiating from loin to groin, sir. So probably it could be in the mid or the distal ureter, sir.
No, I don't think.
Okay, sir.
Distal ureter का reference कहाँ पर होता है? Radiation कहाँ होता है?
Tip of the penis, medial side of thigh.
Medial side
As
of
the stone moves downward, the radiation area moves downwards.
Right, sir.
So upper ureter will come into suprapubic area. Middle ureter goes towards the urethra and the penis, and distal
Right.
ureter and UV junction would be to the tip of penis.
Right.
and medial side of thigh, sir.
Middle side of thigh. Perfect. चलिए आगे बढ़े. So now with your diagnosis of cyst or stone, how do you want to proceed?
Sir, I would want to examine the patient, sir. General examination and general systemic examination and local examination of the abdomen, sir.
What are you looking
And
for?
sir, I don't expect anything specific on examination. I mean, general or the abdominal examination, sir, excepting maybe, sir, flying pain and probably if swelling at all, any, if it is there, sir.
Pain is not an examination finding. Tenderness.
Tenderness, yes, sir.
So you would be
So-
looking for maybe tachycardia, raised blood pressure, and renal tenderness.
Right, sir.
Can you make Hemang Bakshi co-host? Okay. Fine. Ojas, you are also answering, huh? Abhishek
Yes, sir.
is
Yes, sir.
always ready to answer. Yasir, you are also answering. So in
Yes,
between,
sir.
please.
Yes, sir.
Okay. Yeah, go ahead.
So give us the further details, please.
Yes. So on examination, the general examination is grossly normal. On systemic examination, there is only left renal angle tenderness and grade 1 prostatic enlargement.
Okay, Ojas. Now these are
Yes,
the
sir.
findings.
So first, initially, given the first, I will initially like to evaluate the patient after the examination part. First, go ahead with a complete blood count of serum creatinine and an ultrasonography of the abdomen plus pelvis to decide about the further line of management.
Or just don't miss urine routine.
Urine
yes.
routine microscopy.
Urine routine microscopy. Yes.
Urine routine.
So,
Please give the details.
Yeah. So on urine routine microscopy, RBCs are 8 to 10 per high power field, WBC are 7 to 8 per high power field. There's no growth seen in culture sensitivity. In the routine blood labs, potassium is 5.3 and creatinine is 4.4. Rest all is normal.
So are you surprised with this report? What is your impression now?
So first, I will initially like to ask whether the patient has any previous history of any similar complaints, whether there is any baseline creatinine or any previous sonography or any imaging report is available. And
Which has been already told that there was nothing in the previous history.
Nothing. Okay. Then this shows that patient has an underlying chronic renal disease with a raised creatinine, and right now the cause of the pain has to be evaluated. So we'd like to do ultrasonography as the initial investigation to again guide us further. Creatinine is high, 4.4. That will be kept at the back of the mind. The counts are normal. Counts seem normal at this point.
Why should one side symptoms lead to raised creatinine?
So this probably indicates that that either there is chronic renal disease. There has been some kind of asymptomatic presentation which has been going on for a long period of time, affecting both the kidneys, or maybe the patient has a solitary kidney.
Good.
Sir, even there may be reflex shutdown of the contralateral kidney. So that is one more reason. So, sir, I told.
See, usually the reflux will not give rise to 4.4 creatinine.
Sir,
It may-
reflex shutdown of the contralateral kidney, sir.
So that also will hardly 1.82 like that, you know.
What is reflex shutdown of contralateral kidney?
Sir, in the last class, sir, I told, sir.
No, have you read it anywhere?
No, sir, I haven't read it, sir.
So
Yes,
please
sir,
don't talk about
sympathetic-
anything which you can't substantiate.
Right, sir.
Because to the best of my knowledge, I have not read any such things as reflex shutdown of opposite kidney. I want others to comment on this. Is such a thing there?
No, sir. No, sir.
डॉक्टर गीते ऐसा कुछ है क्या?
नहीं सर, कुछ पढ़ने में तो आया नहीं किधर।
मेरे भी कभी पढ़ने में नहीं आया सर.
Yeah, there is nothing in written down in the books. But the practical knowledge, if you go to say, usually whenever there is any injury to any part of the body, you know, usually it tries to protect. The same way here also, many a times we see that patient will temporarily will go into anuria and the creatinine may increase. So many times you also must have seen it, that creatinine is little raised, even though the contralateral kidney is absolutely normal and no other problem is that.
So Gaurang bhai, a lot of times what these days they say is that is because of, say, if the patient has a solitary acute obstruction, then because of the raised intrarenal pressure, there is a perirenal stranding. Now, basically, this stranding is something like a extrarenal urine that gets, so the presentation is more like a urinoma from where creatinine gets absorbed. And here the rise in creatinine is very, very minimal. So acute obstruction with severe stranding can lead to marginal rise in creatinine. But to the best of my knowledge, I don't think कहीं भी ऐसा opposite shutdown लिखा हुआ है. So again, the three causes say why with the solid one side, say disease creatinine goes up. One you said was natively poor kidneys, so acute or chronic. One was a solitary kidney, and third could be a perirenal urinoma because of fornical tear.
Agreed.
Sir, is
Okay.
there something known as sympathetic nephritis, sir?
अगर आपने पढ़ा है तो सब उसको ग्रुप में डालिए, मुझे नहीं पता इसके बारे में.
Okay.
Yeah. Yes. See, you just
Sir,
put
I'm
that
not-
in a group. Okay, from wherever it
Okay.
is written. Okay.
Okay, sir.
A long duration surgery in a lateral position, post-operatively, sometimes opposite kidney may end up into the failure. So ये practically written है sir.
Sir, but doctor, that is more like something like a ATN.
Yes.
So means this word reflux shutdown is something which is odd.
Reflex नहीं पढ़ा.
हाँ जी.
Anyhow, okay, we will go ahead.
बिल्कुल. So give us the sonography picture, please.
Patient doesn't have a sonography. He had a non-contrast CT scan before coming to our OPD. This is the norm.
Okay, but in exam you'll ask for a sonography. I remember it.
Yes, sir.
Yes.
I will zoom and show you the relevant picture. Picture.
I can see. Yes, sir. So these are the cuts of non-contrast CT of the kidney ureter and the kidney and the bladder. I just saw. Sir, on the left side, sir, there appears to be hydronephrosis and in an extrarenal pelvis, and the cortical thickness is thinned at places, sir. And on the right side, sir, the architecture of the kidney appears normal, sir, excepting for a, I think, mid-polar lesion that is arising with calcification in between, sir. Calcification in that mass, sir.
Is the ureter looking normal?
Show ureteric cuts.
Can you make Dr. Hemang co-host? Dr. Hemang.
Right side.
Yeah. Previous picture, previous one. Go back. Yeah, keep this.
So yes, sir. Sir, there is a calculus noted on the left side. It appears near the at the lower ureter part, and sir, there is some thickening of the bladder wall also noted on the posterior wall, sir. Yes, sir. That is what I can. Yes, sir.
I would feel even right side the ureter looks a bit more dilated.
There is some near the pelvis, sir. It is the upper ureter is dilated
Yes,
on
so
the right
we
side
do
also.
not have the other images, but definitely left there is significant hydroureteronephrosis with a lower aortic stone, probably a large lower aortic stone, and right there is a exophytic midpolar mass with calcification with hydroureteronephrosis. We do not know till what level is the hydroureteronephrosis.
Yes.
Okay. Again, my suggestion would be that I don't know whether you should be commenting on bladder wall thickness. You don't want the discussion to go there.
Yes.
See, what Dr. Pankaj Maheshwari is telling you is right. Here, you are going to deal with the ureteric stone and malignancy, and the discussion will go unnecessarily on obstruction.
Okay, sir.
Excuse me, sir. But sir, with an exam, if you see any findings, at least you should mention in that, because they will think, examiners thinking you missed that. You did not read it properly.
Mahendra, I agree with you, but in this patient particularly, we will not really call this bladder thickened.
Yes, sir. Sir, we can say ki, like this thing, some area thickening of bladder wall may be insignificant, like that.
Okay.
Like that. Because there something is there. So the examiner takes in what way, that we don't know.
Sure. Okay.
Lot of background noise from Yeah, another thing is, while commenting the ureteric stone, you should comment on there is a lot of periureteric fat standing at that level.
Yes, sir.
Clearly दिखता है तो comment करना है.
Yes, sir.
क्योंकि क्या है, अगर नहीं दिखता है तो ठीक है, लेकिन इसमें दिखता है क्लियर कट के lot of periureteritis and periureteric fat standing है, तो उसमें comment करने में कोई हर्ज नहीं.
Right.
It is anyhow related to the stone only.
Right, sir.
So,
okay,
Like to ask the HU of the this mass, right-sided mass.
Okay, Paras, just tell us the findings.
Yes. So there is a 3 into 2 centimeter well-defined exophytic lesion seen in the mid-cortex of the right kidney with a punctate calcification within. A 6 mm calculus is seen in the mid-calyx of the right kidney. 14 mm calculus of 870 Hounsfield unit is seen in the left lower ureter with moderate hydroureteronephrosis. There is a small hiatus hernia.
What was the HU of the lesion? Like anything?
Yeah, HU is not. Stone HU is
Not there.
it's
870.
Lesion is not.
Yes, sir. Okay, so sir, initially we would admit the patient. The patient's relatives will be counseled that he has two pathologies. On the left hand side, there is a lower ureteric stone which causes obstruction. and also that on the right side there is a incidental finding. Though he doesn't have complaint, there is a mass seen on the right hand side as well. The patient has an underlying. The patient will be admitted first. He'll be counseled that the obstruction need to be dealt first, as it is causing the creatinine to go of 4.4. The patient also has to explain that that he would initially need to be dealt with the lower ureteric stone in the form of a ureteroscopic removal with a DJ stenting, if possible, or just a DJ stenting in the first setting. And then we would monitor the creat. And later on, we will explain him that we will go for the management of the right-sided mass, but this has to be discussed with the radiologist because this is a isodense lesion, and there is a small calcification. So this will fall under. But this is isodense. So still, okay, sir. The patient has to be explained that this will have to be dealt with after the creatinine comes down after dealing with the left-sided stone.
So 2-3 things. Both the kidneys seem normal size here in the CT scan.
Yes, sir.
So why should the creatinine shoot up?
So the first, though it appears normal size, so first initially we need to hydrate the patient as well. There might be underlying sepsis, which would partially explain the raised creatinine of 4.4.
Probably.
So we have to hydrate. Well, yeah. So for the hydration part and the sepsis, though he's not having fever, but this part would explain the rise in the creat. However, the finding that it will cause a creat of 4.4, that has to be dealt with. The pulse rate and everything was normal. There was no tachycardia. The BP was
No
normal.
problem.
But
So another thing is that, Paras, one question to you. The top left says right kidney measures 1 centimeter by 5.9. That's a typo error?
Type error. 10 centimeters.
Okay. So another thing is this 3 by 2 centimeter lesion, well defined, isodense. I mean, isodense is fine, but we have done a non-contrast CT. So
Yes, sir.
whatever isodense, I think that language the radiologist wants to tell is it looks quite uniform, probably on that plane scan.
yes,
At
sir.
least on the plane scan, yes, sir.
Yeah, so it is probably uniformly solid. But on the
Yes, sir.
plane scan, something like a isodense, it's rarely sometimes difficult. So maybe because additional sonography here obviously will say that it is a solid mass.
Yes, sir.
This
Right.
patient presented with right flank pain. What was the cause of his pain? We still haven't understood.
So left flank pain. So those
Left-sided
causes-
obstructed
Left
kidney.
flank pain. Okay.
Left
ठीक है.
flank.
Left flank pain.
And patient had a left loin tenderness.
Okay. Fair.
So that might be a sepsis on the left side secondary to the obstruction.
Yes.
So had this patient presented with right flank pain also, it would have probably been a passing stone.
Right, sir.
Possible.
Yes, sir.
Mid-calicial stone is there on right side.
Yes.
Okay, so what he has already told the management completely.
So can I ask question?
Yeah. Go ahead, sir. Go ahead.
So once you have dealt with the stone, would you want to repeat if the creatinine is normal after you've done the URS and stenting? Would you want to repeat a contrast CT to better characterize the lesion
Yes,
before
sir.
taking?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
You would want
So
a
what
contrast.
imaging you plan to do?
If the creat comes down to normal, then we would like to plan for a contrast and a computerized tomography of the abdomen plus pelvis, triple phase.
So after
triple
you
phase,
do
sir.
the stone surgery, I am the patient. I am still very anxious about that mass on my other kidney. So how long you want to wait, doctor?
I would initially want to. I will initially in the post-operative period for the first few days. I will see how the creatinine trend is. I like to see
Okay.
how whether it reaches what will be the nadir value in this patient. I will explain him that first has to be dealt with because that is a more life-threatening condition. Whether if he lands up in renal failure, so that has to be dealt with. So monitor the creatinine levels. And after that, we comment when to go out. So if the creat comes down to normal, then we can plan for a triple phase contrast and CT scan, and then go ahead. If the creat doesn't come down, however, I would then then I would plan the.
Okay. Suppose if I ask you this question, the creat comes to 1.8, what will you do?
Creat comes down to 1.8. So then, before going ahead with any other further management, I will like to also explain the patient that we are dealing with a situation in which both side kidneys are having suboptimal function. So we would like to first do a nuclear scan to determine the function, baseline function, and then go ahead. That will be for my safety, as in to know for avoid any medical legal issues, and also to know what was the baseline function of each kidney in both the cases.
Would you like to wait to do a DTPA scan, or creatinine of 1.8 you will go ahead with a DTPA scan? What will be your criteria? Because I asked that question, how much time you will wait? You didn't say that.
So we'll wait for the nadir creatinine level. So
Till two consecutive, we have two consecutive creatinine values, sir. Then we will consider it as the nadir value, sir.
So how apart they are?
So 2 weeks.
2 weeks.
Consecutive can be even today and tomorrow.
No, sir. 2 weeks.
I think we'll ask the house. I mean, any views, anybody, for the students to tell in exam? Because I feel that one answer, that a trend of creatinine decrease can be seen and then decided.
Sir, can we evaluate the mass by an MRI, plain MRI?
Why plain?
You can plain MRI.
Creat.
You can use an MRI contrast also in that case.
Dr. Hemang can guide us.
Yeah, so we can. The first question is valid, asked by Ganesh, that how long will you wait? You have to have a figure in mind, 2 weeks, 3 weeks. Roughly, I think we would all agree to that. So 3 weeks. Ganesh, how long would you wait? I mean, 2 weeks, 3 weeks.
I think we'll see the trend and maximum wait 3 weeks, because we also need the infection here to settle and the patient recuperate for a next procedure. So 3 weeks for a creatinine is very good, and the mass is of a good size, so we can wait.
Yeah. And MR contrast, as very rightly said, we can use if all the create is not down to less than 1 point.
Just can I ask a question? At this stage, where the creatinine is 4.4, any role of FDG PET?
No.
No, sir. FDG PET is as per all the recent guidelines, FDG PET has no role in the primary diagnosis. FDG PET is only used to follow up a patient in case of recurrence. It has, because renal tumors are less FDG of it.
So you would like to do MRI with contrast or with non-contrast MRI?
So at 4.4 we can't. So at 4.4 we can't give even MRI with contrast. So at 4.4 we can't do. If the creat comes down to 1.8, then maybe we can offer MRI with contrast.
So suppose that after URS, this thing the stable creatinine is 2.2 or 2.3. Is it possible? Right. So what imaging would you?
So at 2.2 we can offer an MRI. MRI with contrast could be offered with nephroprotection.
Okay.
Nephroprotection in the form of hydration and
Soda bicarb, N-acetylcysteine, soda bicarb, hydration.
So if it is 3, I'm just asking as a scenario. This scenario can occur, right? So what?
So at 3 ideally we should avoid. At 3 ideally should be avoided. So it will also depend on the institutional policy. But at 2.2, 2.5 we can take it as a cutoff for MRI with contrast. Whereas for CT scan contrast, depending on the institutional policy, 1 to 1.5 would be the cutoff to not offer a contrast.
MRI, PKD or ESD with contrast. What are the guidelines now?
So for MRI, it is till 2.5. It should be allowed with nephroprotection.
There is availability of second generation agent. There are very less chances of nephrogenic fibrosis. That's what we are worried about. So while doing the MRI, in case of the CKD and ESRD, MRI with gadolinium can be done in this situation.
Right.
with 2 or 3 creatinine, doesn't matter. If there is availability of gadolinium agent of second generation.
Right. So let's go ahead, I think. Suppose if we are going to do a CCT, as you said initially, what all information you list we can get about in the CCT?
So initially we like to see how much is the enhancement of the mass on addition of contrast. In the early arterial phase, if the enhancement is more than 15 ounce per unit, that will indicate that it is more likely to be
Next.
Second thing, we will like to assess how is the
Location.
uptake.
See, Paras, you are answering, right? Try to tell in short and complete your list rather than, writing an essay every time.
Yes, sir.
Exam time for a case given is 30 minutes or 35 minutes. If you get into this habit, every sentence, one point you are saying 3 minutes. I would just say contrast enhancement, heterogeneous, solid mass. Words with sentences are welcome.
Okay. So look for the enhancement pattern, to look for the surrounding other the vasculature, how many arteries and vessels are present, to look for any surrounding lymph nodes, to look for the function drainage pattern of the kidney, excretion pattern of the kidney, and to also assess the ureter and the rest of the surrounding abdominal organs.
Okay, I would see the lymph nodes. If I am you, I am the student, I will set a renal score to it. If I am you, I might see, there are many more things which you can nicely say and format your answer to impress the examiner. Okay. Remember that in exam. This was not a very good answer.
Okay.
Sir, in EU guidelines, there are 7 factors that has been described whenever anybody sees renal mass. So you please remember that and learn that.
Location, size, sir.
No problem. Let's go ahead. So for this kind of, say 4 weeks have gone, creatinine is okay. You have done a CCT triphasic. Have we done really?
No, sir. Patient underwent left URS with DJ stenting. The creatinine came down to 2.8 after.
No problem. Let's consider that it has finally come down to 1.7. Now, what kind of treatment you will offer for the renal mass? What do you think?
So open right-sided partial nephrectomy would be offered to this patient.
So, sir, after evaluating the mass, sir, I would explain the findings of the CT and the need for treatment of this mass, sir. I would offer one of 2 treatments to this patient, sir. One line of treatment would be a biopsy and a focal therapy, sir. Other treatment would be a nephron sparing surgery, sir. That nephron sparing surgery may be done by a lap, robotic, or an open technique, sir, which as per the institution protocol and whatever I am proficient in.
Okay, because but want to go on ablative therapies directly after a biopsy.
Sir, 3 into 2 centimeter mass, a small
creatinine comes down, this patient, the sepsis goes away, this patient is nicely operable.
Yes, sir.
I mean, one of the things which we go with ablative therapies is the moribund patient, old patient, frail patient, who may not be technically fit for surgery, or the only reason is that fit patient who is totally against surgery.
Yes, sir. He is 60 years old.
A very good reason for us surgeons to say in exam, probably.
Right.
So should we offer active surveillance for this patient for 3 centimeter?
For us, I mean, Abhishek, you can answer.
I
personally
surveillance
only.
If he is absolutely not willing for any kind of treatment, only then, and that too with the explanation that during active surveillance, if untoward changes occur in the mass, you would have to go ahead and operate that mass. Rather, I mean, if he's not willing for anything at all, then
60-year-old.
60-year-old,
exactly.
Exactly.
3 centimeter tumor.
So this patient is 60-year-old with yes, sir. With good cardiovascular performance is 100%. There is no comorbidities.
Good to be operate him. Surgery. Yes, I would say surgery is the first option. Probably best option.
Right.
So unless the examiner wants the conversation in direction of ablation or active surveillance, we should not mention it, right?
Okay.
So
yes, sir.
the first choice problem.
In continuation with the Bakshi sir's question, patient had a marginally deranged renal function, less than 3 centimeter tumor. So why not active surveillance?
Sir, we have to characterize the tumor, sir, by a biopsy, sir, find out the grade of the tumor and actually prognosticate the tumor, sir. Only then we will be able to offer active surveillance, sir.
I agree. So there is a criteria to decide active surveillance. So
Yes,
indication
sir.
of you should know all the things in one go. Then only you can able to defend in exam.
Yes.
Yes.
So I feel still, as far as our exam is, their first option should be surgery.
Agreed.
Yes, sir.
So who
Okay,
said, probably you said all options, Abhishek. Open lab, robotic, वगैरह वगैरह. Examiner will hear that, but finally ask you what will you do. So, and what precautions you will take while counseling this kind of patient. तो वो बताना पड़ेगा तुम.
Yes, sir. Sir, I would prefer open partial nephrectomy in this patient, sir, and with the explanation that I will explain the patient that this about ischemia time, sir. I would explain the patient, and then, sir, the completeness of the resection I will explain, sir.
Okay. So doctor साहब पूरी kidney तो नहीं निकालेंगे ना?
No, sir. It will be only removal of the mass, sir.
Guaranteed.
Okay. डॉक्टर साहब
No, sir, we have to explain
अभी भी
about
मैं
this
कंसेंट लेता हूँ
radical.
पेशेंट से पार्शियल एसओएस रेडिकल नेफ्रेक्टोमी. And technically, I tell each and every patient, 25% of the cardiac output with each heartbeat goes to the kidneys. That tells me 12.5% goes to one kidney.
Okay, sir.
So if there is bleeding, if there is worse bleeding, there is still a 0.51% chance of a radical nephrectomy or total nephrectomy. So
Okay.
I think that should be factored in your complaint counseling. Again, two main complications are bleeding, which can happen even post-operatively, sometimes rarely. The second is the urine leak. Whatever
Yes,
is that, we have seen an NCCT right now. And the
Yes,
position
sir.
that it is somewhere interpolar here, there I can't gather.
We do not know the nearness or the involvement of
We
the
don't
pelvic
know.
LHC system. Yes, sir.
Yeah, so remember, and it is better to tell the patient as a small incidents which may happen. If you then think about what I said initially, renal score, it gives you a percentage of these complications. That say 10%
Right, sir.
rate of complications, 11% rate of complications. So all this should factor in your counseling. And open partial nephrectomy is well taken. So ischemia time, I don't know whether I will discuss with the patient in counseling, because I think in that case, if I am not too sure, what do you think? You are going to use warm ischemia or you are going to use cold ischemia?
Small mass, sir, I would go ahead with warm ischemia only, sir.
You will go with warm ischemia, okay. So how much warm ischemia you think is good?
Sir, I think
30 to 35
I
minutes.
should be done by
Ideally 20
10
minutes.
10 to
Ideally
15
20
minutes
up
I
to
should be
30.
done, sir, and up to 20 minutes, 18 to 20 minutes is ideal, sir. I should be done by 10 to 15 minutes, sir.
Okay, so rough time is 30 minutes clearly, okay.
Okay, sir.
Yeah, I think, and I don't know, but एकदम exam में जाओगे तो don't utter these words. I should be done in 20 minutes. I should be done in 15
No,
minutes.
yes, sir. Yes,
The best
sir.
of the surgeon, even I have spent time more than 30 minutes many times.
Right.
And the time is spent because of suturing, there is some bleeding, there is this thing, that thing happening. So don't commit yourself to 10 minutes or 12 minutes also. And
Okay.
in case a safer thing in exam is still, with my experience, I would like to do a cold ischemia, clamp with the eye touch, then use the whole more 50 minutes to do a nice procedure, which the examiner probably will easily accept rather than have a jugalbandi about ischemia time later on.
Right, sir.
So
Regarding the counseling, we should basically explain the patient about the diagnosis, so second, the treatment options, and then the complications related to the surgery we are doing, and follow-up, sir.
So specific question, will you clamp the artery? Will you clamp the artery vein? Will you clamp only the vein or not clamp it?
So we'll clamp the artery here, sir. Vein is not required. This seems like a more of an exophytic lesion. So
Okay.
we'll just clamp the artery. So artery would be enough.
And how will you start cutting the tumor after clamping?
Sir, by scissors, sir. As in a cold knife or a scissor.
How much margin will be kept and how much margin is necessary by literature?
So according to recent literature, even one cell layer margin is enough. So we would take ideally a 1 or 2 millimeter margin. That should be enough, but that would depend on the surgeons while operating, palpating with the hand, manual palpation, and that will determine.
Suppose you have cut the tumor and we see that there is a calyx which is open now, minor calyx, and there is a vein and probably one more artery aside. So how will you think about doing the closure, nephrorrhaphy?
So this
What
will,
is your idea of doing a nephrorrhaphy?
So two-layer closure. So we'll first close the calyx using 30 Vicryl, which will involve the inner layer, and with applying clips at both the ends and applying bolsters for hemostasis, where we'll close the calyx and the inner parenchyma, then close the outer layer with a 30 Vicryl, and then again place clips on either side, tighten the sutures, place the Xerotas fascia over it so as to cover it, and also that the calyx is open, so he will need a DJ stenting as well. Ideally, I will put a DJ stent, sir.
I didn't get that last sentence. Sorry.
Sir, DJ stenting would be required for this patient.
Okay. So probably my take on that for you will be, wherever you have seen your institution, try to say that protocol, because at least one support you get is, this is our institutional protocol. But see to it that you answer something in a sane manner. If a calyx is open and a vein is seen open, I would definitely individual suture it. What suture material you use is your institutional. I may use 4O or a 5O PDS for that, which has very good knotting property. Second, after individual suturing, there are various techniques of suturing for a nephrorrhaphy. The robotic one, which is nowadays used many times in open surgery, is an inner layer and an outer layer nephrorrhaphy. Okay, the outer layer takes only the cortex. The inner layer tries to take the medulla, but when you have done individual suturing, there may be times when you can skip the inner layer, or at least don't go again through the same vessels. There is a more chance of having AV malformations.
Okay.
So these are some things which you should remember. Again, in robotic, we do continuous suturing, but it may not be copied in the open surgery. We can just go with things have worked in past also, and be somewhere clear on what probably was your institutional protocol. Because you answer that best, and if the examiner tries to twist you, you might even know the troubleshooting which has been done in your particular institute, and you may be able to answer back.
Yes.
Okay, I mean, Hemang sir, kuch aur addition hai to boliye please.
Yeah, nice. So Ganesh, now Dr. Hemang, he has got multiple cases, and at the end,
I know,
there
sir. I had seen that panel on Sunday morning. I was sitting in the audience.
So I think in all the cases he has covered all the different complications.
तो चालू करते हैं sir directly.
वही मैं बोलता हूँ. Hemang, you can share your screen and you can start. And
Ganesh, before you proceed, I have one question for you. Like in this patient who has a history of stone disease and calcification, would we do a biopsy before going ahead with partial nephrectomy? Because this could very well be a, say, focal XGP.
Okay, but I don't know. The CT probably shows it as a nice round solid mass. No?
Yes, it does.
And if we have even a creatinine comes to 2.3, we can have an MRI which will actually characterize it very well, giving us a very good percentage that it may look like a malignancy. And if I contemplate partial nephrectomy for this kind of, I am pretty sure that I will be able to achieve it. So we are removing only the mass, then it is okay, not doing a biopsy.
And in today's time, with for a 3 centimeter mass, say if I'm going to treat this patient, do I need to give
Yes,
him
sir.
an option of active surveillance if the patient is fit, or it's okay not to discuss active surveillance?
Sir, I feel unless we have multiple small or a VHL, or then we are still away with a moribund patient somewhere. If I have a 74-year-old with a 2 centimeter
No,
renal,
I'm very specific. So this patient is otherwise fit.
so I think this patient I will operate, sir.
So you will not even give him the option of active surveillance.
I will not, sir. If he's fit, I'll not.
Okay.
Because 3 by 2 centimeters, I presume whatever he will have 15-20 years of life.
True.
So why to have active surveillance? It will definitely grow in size.
Because these days there is a lot of literature where they say that less than 4 centimeter, always
Right.
do a biopsy, and the possibility of it turning out to be non-RCC is nearly 20 to 25% as per the.
25% benign. But
Yes.
what even I explain in my OPD is that there is a chance of 25% benign. I have just explained this last week, but I tell them that I'll remove only that. So it is okay.
Fair.
But there is a 75% chance of malignancy.
Mhm.
It means in counseling them that when we are doing a partial, we take a consent for radical.
True, exactly. Because we
That is
also
a
take
greater
a consent
problem.
for radical, we talk of bleeding, we talk of complications, and then we say that in 1/4 chance it may be
25%
an
chance of
indicated surgery.
benign.
Ah.
Right. Clinical
So
call
Paras,
has-
I can just tell Paras what we did and what was the final diagnosis.
Yes, sir.
And then Hemang, you can
Share the
later
screen.
on you
sir.
can
Hey,
just take over.
Paras, please
Paras,
stop
can you
sharing
just
the
tell us?
screen.
Yes, sir, yes, I will stop this. So we did a left URSL, and after 3 weeks we repeated the blood investigation. The creatinine came down to 2.8. So we did a non-contrast MRI. MRI was suggestive of renal score of 8. So we did a robotic partial nephrectomy. The biopsy report turned out to be papillary carcinoma T2 T1.
Okay, fine. So I request Dr. Hemang Bakshi.
Yes, so I'm trying to share screen from a mobile. I'm sorry, I'm logged in from the hospital. I don't have a laptop now. This is a problem. Can you see the screen? No.
No.
सर आप किसी को चाहिए तो email कर सकते हैं, like Mahendra or Dr. Gaurang sir or somebody, and
Just
they
get-
can see the thing for.
Yeah, so I can mail the presentation right away.
Mahendra को कर दो. Mahendra will be.
No, sir, I'm on mobile, sir.
Then Paras को कर दो. Paras, give your email ID.
Yes. Chat box.
Yeah. Please tell. Please, can you speak?
Yeah, drparas2009@gmail.com.
All small, right?
Yes.
Dr. Paras 2009 at gmail.com, right?
Yes.
Right? Okay.
Yes.
Yes.
Great. Just a moment. Sorry about this.
Sir, so we'll continue the discussion. Pankaj sir.
Yes.
I think in future, this I was just thinking when we were going on Dr. Hemang sir's slides. In future, probably this 25% will change. The CT features and the MRI features. Nowadays, we can really tell much better कि I still say 25% malignancy, but invariably every other mass comes malignant only. And maybe with the application of radiomics and AI, it will even better, probably with the data which will come in. This is what I feel, and this is a perspective.
Because recently I heard a talk from, say, UCLA. I'm forgetting the name of the person. He has done a lot of work on partial nephrectomy. And he was very categorical that don't do a partial nephrectomy without a biopsy.
Okay, I think this is coming up in US a lot, and
Yes.
then literature
They
also
have
says that
called it as a bias protocol, means biopsy indicated active surveillance versus partial nephrectomy.
Right.
And because even say if it is malignancy, if it comes as a papillary variant is likely to be a very, very slow growing, slow progressing disease.
Right.
If the tumor is less than 4 centimeters, the risk of metastasis is near zero.
Right.
So
So I guess, I mean, I'll have to read more into that. And somewhere I still feel it may also have some bearing on the US insurance and something. Because all these studies are sometimes financed in such a way that they turn the industry one way or the other.
True.
So I really don't know. I may be wrong in saying that. But
so I found that talk was means so much pro biopsy and also active surveillance in fit people. Even after biopsy, if it comes as papillary, saying that it's a very slow disease, they would keep on doing annual assessment of the rate of growth. And if the rate of growth is less than 5 millimeter per year,
can you share?
They still feel that the possibility of, you would intervene
not offer active treatment.
more than 5 millimeter.
Right. And anything about the patients, how they agree with that active surveillance, or they have no choice?
He presented a study of nearly 400 patients where only 3 insisted on a surgery. So they went to the extent that if you give enough time and say counseling to the patient, no patient will not choose active surveillance.
Okay, but I still feel it is very difficult in an Indian scenario, where I am still advising active surveillance to prostate cancer patients who tell me, I want a surgery.
True. No. You see, I have suggested active surveillance to so many patients, and they come after 6 months where they have already undergone a surgery.
Sir, can I interrupt?
Yes, please.
Mahendra, please go on.
Sir, it is only active surveillance, sir, only for those patients who can understand the strategy.
True. Patient's involvement is extremely important.
And sir, the main thing which bothers the patient is I am living with the cancer. Whether it is a small one, it is a 0.5 centimeter, it is a 2 mm. But the cancer inside my body, only that anxiety, I think forces him to get operated.
So, Mahendra, this is exactly what they said. If you spend enough time and explain to the patient, means he made a very interesting and a bold statement saying that if your patient insists on surgery, probably you haven't explained enough.
No, sir, it's the other way around, sir. Only those patients will force for surgery who was very much apprehensive and scared of the cancer world. Otherwise, well-educated person who wants to remain remain normal life and other things, they opt active surveillance. And at least in India, at least we are little bit had different psychology. So that's why in India we have very less patients with active surveillance, and in abroad it we are just a reversal, maybe more than double, triple time than us.
Yeah.
That is the only reason.
When you listen to that Canadian fellow, what is his name, who talks about active surveillance in CA prostate,
yes, sir.
It seems that there is really no other treatment option.
Sir, in India, patient cries. Even it is a stage 1 disease is low risk. Okay, sir. The patient cries only for this because he is having cancer. So the psychology is totally different, sir. That is the reason the AS the patient who is opting for AS are very less. Even in RCC also, even we assure them this is the very slow growing tumor. It will not, only few patients will opt for AS who really doesn't want surgery. Only those will opt for the surgery. Otherwise, all will go for surgery.
No. So my question was, Mahendra, totally different. My question was that in your practice with such a patient who is fit, would you offer AS or you would not offer AS? That was what I wanted to know.
Sir, if tumor is small,
in this patient,
AS as a borderline, I have to explain the patient as per the indication, whether 3 centimeter can be an option, but with pros and cons, less his choice. He will choose that whether he wants AS or not.
So you will give him the offer.
It is a borderline indication. It will be the borderline indication.
Fair. बस मैं उतना ही समझना चाहता हूँ.
Yeah, we same thing. One thing, sir, again I want to with the Abhishek, while elaborating the management, he used one line which actually I caught long back. He said, I will offer him open, laparoscopic and robotic surgery as per our institution protocol. So I think the treatment-wise thing, you should not use institution protocol. And then again, he said, as per my expertise. So I think it should be avoided. Investigation, it is okay in the investigation, but when the management, what guidelines says, that you have to say.
Abhishek.
Okay, sir. Okay, yes, sir.
Hemang, I have got it
like that,
on a laptop.
I tried. I could not do it.
Understood, sir.
Okay, and whatever the patient want and theoretically fit for him, I will, if prepare available at my institute, I will do that. Otherwise, I will refer. That will be the better.
Okay.
Hello.
Okay, from your end, right?
Yeah. Okay, so I will just show the slides and Dr. Hemang will ask the questions to the candidates, and then we will have all of yours expert opinion regarding all these things. Okay.
So this was our West Zone Symposium in Nasik, and had a good discussion on.
Yeah, and we had all Dr. Ajit Sawan, Himesh, Anup, Sharma, Vivek, Santosh, and Umesh. So they, of course, the students cannot be compared with them, but I'm sure that still with their good knowledge, they will be able to answer. So the basically the objective was to define the role of appropriate use of technology and in the different situation, discuss the management of tumors in unusual situations, like today we gave you left-sided stone and right-sided renal mass. So many different questions were coming up, and to define the management. So I'll just tell Dr. Bakshi.
Okay, we'll have.
You just take over. You tell me when to change the screen.
Okay, sir. You can start. Yeah, you can start playing the slides. Next slide.
Okay.
This first case, he is a 54-year-old hypertensive male, incidentally detected right renal mass on ultrasound done for evaluation of hypertension. He has no urinary symptoms, no flank pain. Heterogeneously enhancing, partially exophytic middle pole mass, 3 by 2.8 centimeters. Good performance status, no comorbidities except hypertension. And next slide, please. Gaurang, can we move on?
Yeah, I'm trying.
Okay. Okay. So this was the CT. You can see the heterogeneous mass. It's partially exophytic, mid-pole, and clearly an RCC, and clearly okay. What treatment would you want in this patient? what treatment would you offer?
So let us start with Abhishek. Abhishek, this case now belongs to you. You answer in this case.
Yes, sir. Sir, I would first calculate the nephrometry score in this patient, sir. And sir, on the basis of that, this appears to be on the given screen, sir. It appears to be close to the pelvic calyceal system, and this appears to be there is enhancement of the walls, and there appears to be areas of necrosis and heterogeneous enhancement inside also. So, considering all this, sir, mm, I would offer I would offer this patient radical nephrectomy, sir.
Why radical nephrectomy? I mean, suppose the nephrometry score is 8. I don't have.
Sir, it is approaching. The mass is lying between the two polar lines, sir, and most of the part is endophytic, and sir, it may be invading the PCS, although there is no hematuria or any renal symptoms, sir. And then it is near the hilum, sir. So,
So this is a 3 centimeter mass. Try not to speak in an exam also that I would offer straightway a radical nephrectomy. Especially this, you can see part of the mass is exophytic. I had also mentioned in the previous slide, I unfortunately have only these 2 images right now. But I would say about 30% mass was exophytic on the other images. So would it change? I mean, this is a T1A disease, right?
yes, sir.
T1A is a partial nephrectomy, and I mean by all.
Yes, sir. Yes, sir.
Yeah. I think you should be speaking partial first, with a consent, of course, for a radical if situation so demands. But you would want a partial nephrectomy in this patient.
Okay, sir.
Because 3 by 3, 3.3 by 2.8. I don't think you should be, unless the mass is come. So when would you do a radical nephrectomy in a T1A? Would be a completely endophytic hilar tumor.
Yes, sir.
Major vessels, then probably you could say this. Any other comments from the other experts regarding the indications, partial versus radical in this patient?
Ganesh,
Dr.
Mahendra, you want
Could
to
you
comment anything?
Managing committee member
Hello, sir, can you hear me?
ঠাকুরের মণ্ডপের সামনে মায়ের মণ্ডপের সামনে চলে আসতে
So Mahendra, you are saying something?
Yes, sir. One thing, if tumor is totally endophytic and it is near the hilum, so recently we can actually perform anatrophic nephrotomy, like we do for the stone surgeries, and we can bivalve the kidney and safely remove the bladder. We have 4 cases, and I recently put my video also in one competition. I also WhatsApp with that. So long-term results are almost similar to the NSS. After 3 months, the DTPA scan was almost as a pre-op, and the kidney shape is maintained. There is no any residual tumor after 3 months. Margins were free. It is a safe approach with minimal acceptable peri-operative or comparable actually outcome with the open partial nephrectomy, other nephrectomy.
Yeah, so partial nephrectomy should be done whenever possible. We completely agree, and that is what we were saying, that the student, even endophytic tumor, we would want a partial for T1A tumors as far as.
Yes. Only thing is that if a partial nephrectomy compromises the supply of the other remaining kidney, then it is not feasible to risk the of blood loss and other comorbidities.
The major renal artery being very close or within the capsule or something, then we might end up with a nephrectomy. But by and large, the first option would be a partial for all T1A tumors, right? Regardless of what approach you use, whether you use open lap or robotic. Anyway, we'll move forward with this. So, can we have we decided to go for a lap partial. So it's a video which shows the artery and the vein being skeletonized. Gaurang bhai, can you fast forward this to roughly half of what in the middle? So, the 4-minute video, but we need not show all the parts. So the sequence of clamping, anyway, yeah. So we clamped the artery, we clamped the vein, and we proceeded with a lap partial. But the moment we started with the partial nephrectomy, it started bleeding, right? So we went and removed the clamp on the left renal, on the right renal vein, but it still continued to bleed. You can see the bleeding here, right? There is hardly any vision. And we still went ahead for some time, for a couple of minutes more, unclamped the vein, tried to go off as fast as we can, but it still bled. So next slide. Okay, what will you do now? We are on clamp and bleeding. We have taken off the venous clamp. Would you convert it to lap nephrectomy? Would you want rapid excision of tumor? And or would you convert to an open partial?
Sir, with this much bleeding, sir, when vision is obscured, sir, I will convert into open partial nephrectomy, sir.
Perfect. So that is what we're aiming at. So, I mean, lap nephrectomy would be an easier option, but we should save the kidney as far as possible, right? So, partial nephrectomy would be the treatment of choice. We could go ahead and open it. That's what we did. Next slide, please, sir. Okay, we did convert this to an open partial. It was a clear. It was uneventful then. The post-op recovery and everything. Clear cell RCC, negative margins. PT1. Next slide, please. Okay, discharged on 4th post-op day. 3 weeks later, the patient presented with hematuria and clots. We did a cystoscopy and clot evacuation. His vitals were stable. Hematuria stopped and patient was discharged after 3 days. 10 days later, he again presented with a second bout, hematuria and bladder clots. Okay, second episode. Next, please. Okay, how will you then go ahead and manage this?
So the hematuria could be probably because of a pseudoaneurysm or AV fistula, sir. So
Right.
I would want to do a angiography, digital subtraction angiography, and then proceed with the embolization of the fistula, sir.
Perfect. Next. So this was an ultrasound which we did, which did show on a vascular study churning of blood within the mid-pole lesion where the surgery was done. Next, please. And this was the CT. So it will show the pooling of contrast here on the right side, as you can see. These are the still images. You can see the blush here and,
yes,
and blush on the left-sided image. And then we put in a coil and the bleeding stopped. Next, please. Suppose angioembolization is not available. You don't have the facility. Would you prefer operating on him? The patient wants to get this done at your institution. It doesn't have the facility. You are in some remote place. Would you consider other options like sclero or open surgery or nephrectomy, partial nephrectomy, suturing of the lesion? Would you consider?
sir, I would consider.
Yeah.
Sir, I would consider exploration and sir, ascertaining the site of the bleed, and then proceed with the proper hemostasis and other management. So nephrectomy first upfront, I will not consider, sir.
Okay. Would you consider shifting the patient to a center where these facilities are available?
Yes, sir. Yes, sir. Indeed.
That
yes, sir.
saying in the, I believe that you should be saying in the exam first that if you, I
Right,
don't,
right.
I'll try and refer it. But if the patient, I mean, if for some reason that is not possible, patient is hemodynamically unstable, etc., then you would want to.
Okay, sir.
Okay, what would you want? Any tricks to prevent this kind of mishaps happening while doing your?
Yeah. Sir, during a partial nephrectomy, I would want to be meticulous with the resection of the tumor, sir, without causing any inadvertent injury to vessels and preventing bleeding as much as possible, sir.
Yeah, but you are on climb, so that is done. Resection part is okay, but after during rhinography, most of the times the AV fistula occurs because you have taken en masse sutures with the artery in very close proximity. So
yes,
a better thing, as you said in the previous discussion, would be to close off the individual vessels, as Dr. Ganesh said, with fine sutures 3040, whatever material you want, but close off the vessels individually as far as possible to prevent this from happening, right? So that should be the and of watertight closure as far as possible, the collecting system, the vessels individually, and then the second layer. Okay.
Right.
Next.
Okay, so Ojas, now you can answer.
Yes, sir. Yes, sir.
Okay,
No
3 by
fight again.
centimeter endophytic mass, 43-year-old man, incidental finding, normal contralateral kidney, no comorbidities. Okay, 3 by 2 endophytic, and this is the CT, completely endophytic. No, nothing.
Yes, sir. Yes, sir. So this appears to be a complex tumor. I will calculate the renal score here. So renal score, the size is 1 and 4, 4 and 7, and renal score will be approximately 10, sir, over here. So this is the complex tumor.
Right.
This now the opposite side kidney is normal. This patient can be offered a partial but higher chances of conversion to a radical nephrectomy.
Correct. So you will prefer a partial with a chance for a radical, right?
Radical, yes, sir.
Within a consent for radical.
Consent, yes, sir. Consent that it might likely get converted to a radical or might likely get converted even to an open surgery if you try to do a nephron sparing surgery.
So what procedure, what approach at your institute would you want? Would you prefer, I mean, open lab, robotic?
So if I am the operating surgeon, I would offer an open surgery.
Right. Would you take any specific precaution, or would you want some additional investigation, or like else in the theater?
I will reserve blood, keep blood ready in the operation theater, inform the anesthetist during the dissection part that if there is any bleeding, that keep at least one blood ready in the operation theater during the dissection part. And also before the surgery, ask the sister to keep open trolley ready. Sorry, we are doing an open only. So yes, sorry, open trolley ready and vascular clamps ready if required, sir.
Yeah, you
vascular
would
clamps, sir.
Mainly all these, of course, are very essential, but you would also want an intraoperative ultrasound, right?
Yes, sir, ultrasound, intraoperative ultrasound. Yes.
So because without that, you will not be able to palpate. I mean, it's very difficult to palpate an
Yes,
endophytic sac. So that's a mandatory thing. If you are doing an open partial, regardless of what you use, warm ischemia or cold ischemia, you would want an ultrasound to be present. That should be the first thing, apart from the other things which you said very rightly are necessary. Next, please. Okay, so we did this. We did an operative ultrasound. You can see the tumor on the right hand side, and
yes,
very well in the next. Next, please, sir. Okay. As Dr. Mahendra said, we can bivalve. There are two ways of doing this. We can bivalve the kidney as you would do an anatrophic nephrolithotomy. I prefer excising a little more of the parenchyma by going around it. You mark the kidney as you would. Here you remove a small wedge of normal parenchyma. So
yes,
what you essentially do is remove a little of more of parenchyma than what you want. What would you do in an bivalving approach? But here you are a little more safer because you go around the tumor. You don't enter. There is no risk of entering the tumor. So that's just a technicality. You can do it either way. I prefer this way.
yes.
Next, please. Okay. Would you use cold ischemia?
Yes, sir. So this I would use cold ischemia in this patient because this is a more complicated tumor. The renal score is on the 10 to 11. So I would use cold ischemia, which would provide longer time for me to go ahead with the dissection. So I would use cold ischemia. I would first clamp the artery. Even in fact, this is a highlight tumor. I clamp the vein as well. Then put a plastic sheet, make a hole in it, put the kidney, lay around eyes, and after 15 minutes, start with the dissection part. So I will use cold ischemia. Yes.
Okay. Are you aware of any studies comparing cold versus warm ischemia?
No, sir.
Last year, there is a published randomized trial comparing the two. I had included in the final presentation. Okay, here it is. This is an RCT published in the Journal of Urology, and it concluded that there is no difference in whether you do cold or but it is fine. I mean, whatever your institution protocol is, you can speak in your exams that this I will do. But you should also be knowing if the examiner knows and asks you whether there is an RCT or whether whatever evidence there is, you can always say that the evidence in an RCT shows that there is no difference, but I would still want to do it. So it is that you should be knowing.
Okay. Yes.
Okay, next slide. Okay, this was the specimen and this was an RCC. Next, yes. So a couple of which we have already discussed, I think. Next, please. Okay, 62-year-old female. You can stop her, Gaurang, by whenever. I mean, the time is up. I don't know. So,
No. You go ahead. We will ask them.
Okay. 62-year-old female, hematuria, 5 by 4 by 3 centimeter mass on the left side, heterogeneous enhancement, partially exophytic, posterior hilar, and close to the renal vein. So complex tumor, and I will have the CT in front of you. Yeah, CT on the left and right. MR on the right hand side, so you can and we also have still images come. Next, Gaurang, if you can have the images. Yeah, so you can see on these scans, it is an exophytic, partially endophytic, but very close to the renal vein, as you can see on the CT. And it's a complex heterogeneous tumor, T1B, hilar mass, posterior location, the most difficult to do partial on, right? Okay, what factors will... So would you go ahead with a partial or a radical in this patient?
Sir, in this case, I will go for the radical nephrectomy because the renal vein and very complex tumor, sir.
Okay, would you attempt a partial?
Yes, sir. Open partial nephrectomy, I will attempt. If not possible, I will explain in the patient. Before only, I will counsel the patient that there are chances for the radical nephrectomy.
Okay, open partial. Okay, the next two questions were 3D printing. I don't think they would ask you in exams, but I mean, you can use in such cases. There is no evidence to say that it. I mean, there is some evidence. There are a couple of studies involving the iris software. Recently, abstracts have been published saying that it changes management and it, helps the surgeon in deciding. But would you do a frozen section on routine partials?
Yes, sir. If it is available in the institute, that I will definitely use the frozen, sir.
Okay, in all partials, would you use it? Or when would you use it?
When the tumor is more complex, sir, only then I will use. Not in the, if I can easily remove the tumor. If it is very exophytic and small tumor, then I will not like to do the frozen section.
So whenever you suspect a tumor violation or you suspect some tumor in the tumor bed on visual inspection, you would go for frozen. So it's not a routine practice. Routinely, we don't do frozen. Most of us don't, and it's not recommended also that you have to do a frozen. It's not a mandatory thing. And ureteric catheter stentings before partials?
Yes, sir. Being a complex tumor, I will like to put in ureteric catheter. so that intra-op I can use the methylene blue. During the dissection, I can use the methylene blue to see if I have entered the PCA system or not.
Okay. It's an individual thing and institutional thing. I don't do it ever, but you can do it, I guess. Most people don't. Next. Okay. So we did a robotic partial on this patient. You can see a tumor on the left hand side. The curtain complete and almost right. So the standard in. So the histology should positivity at two places, the tumor base and the extent of positive margin was 3 mm and 2 mm. 2 positive margin, what would you want to do? Completion nephrectomy versus observation, and if
observation, sir.
Okay. When would you consider a nephrectomy, if at all, or you would of the all cases?
If there is global margins are positive, then only I will consider the conversion to this radical nephrectomy.
Yeah, multifocal positivity of margin, or grossly you can see that you have left some tumor behind after, which can happen sometimes in lab because the instruments are not responsive. So you might sometimes go through the tumor. I mean, if you are an expert, you won't do that, but it can happen. So if there is gross violation and you see that probably some part is left behind, you would want to do a complete nephrectomy, or there are multifocal positive margins. You are sure that you have left behind something, you might do. But otherwise, observation would be the treatment of choice. Okay.
So follow-up. You were asking about follow-up schedule.
Yes, sir. As per the EUA 2022, the follow-up schedule, if the margins are positive, even focal, the only thing that we do is the follow-up schedule has to be more frequent than the routine ones.
Frequent means what? How frequent and what you will do?
Sir, first at the 3 monthly, we will do the CT scan. If it is negative, then after 6 months, 6 monthly for the 3 years, we will do the USG.
Ganesh, Mahendra, can you just comment?
Sir, we have to first stratify the risk of recurrence in localized cancer. There is a level which score where we can post HPR, we can calculate it, and we can categorize it low and intermediate and high risk patient. And based on that, we should individualize. So normally, it is 6 monthly for low risk.
Yes, sir.
With annual CT scan. For high risk, it is 3 monthly. And alternatively, chest X-ray and CT scan chest, CT chest, along with the CT scan abdo-pelvis. So you whenever you read follow-up, so please ever see a prostate, even renal mass. There is some different some difference between the other follow-up. You have to categorize as per the risk classification, and then you have to plan follow-up. Okay. You cannot follow up all patients in the same schedule.
Okay. Fine. Hemang, shall I change the slide?
Yes, sir. Okay. So next case, 46.
Abhishek, you can answer.
Yes, sir. Yes, sir.
46-year-old man, no hematuria, no comorbidities. He had a history of perforated appendicitis treated by a laparotomy before 9 years, right? Next, please. This is a T1B renal mass. As you can see, most of it is phytic. size is 5 by 4 centimeters, posterior, upper pole.
Yes, sir.
Okay. And there are two moieties here, upper moiety and the lower moiety, and there are two stones in the different moieties. So you have a 3 millimeter stone in the upper moiety, a 7 mm stone in the lower moiety. And the tumor is located in the upper moiety, but we have a fair bit of parenchyma left in the upper moiety. So,
yes, sir. So I want to assess the function of the upper moiety, sir. Appears to be functioning because there is dye excretion.
Yeah, you can see the IVP is on the right next. It is functioning quite well.
It is functioning, sir.
Yeah.
And sir, I would want to also evaluate. It is a functioning moiety. So, sir, I would consider doing a partial nephrectomy of the upper moiety, sir.
Perfect.
Because this mass is fairly exorbitant, so a partial nephrectomy can be done, sir.
Right. Next slide.
Stone.
Yes, sir. Abhishek, answer one question.
Yes, sir.
Stone or tumor, which should be treated first?
So, sir, there does not appear to be any hydronephrosis or any untoward consequence because of the stone, sir. So, sir, the tumor should be tackled first, and in the same sitting, stones can also be managed, sir. And should
Stone is more.
yes, sir.
What you will do, Abhishek? Just tell us.
Sir, both in the same sitting, sir.
So you
Open lab.
will do URS and you will do partial nephrectomy.
Yes, sir.
Abhishek,
And yes, sir.
upper moiety involves only one calyx, lower moiety involves two calyces. Okay, and upper moiety there is a tumor, whatever may be the size.
Yes.
After removing that tumor, how much upper moiety is remaining behind? So you want to do upper moiety nephrectomy or you want to just remove the tumor?
Sir, I would want to prefer
because already in that urethra also there is a stone also.
Yes, sir. Sir, I would want to preserve as much of renal parenchyma as possible, sir. And since
anyhow there is a single calyx in that moiety, that is upper calyx.
yes, sir. Still, I would want to preserve the parenchyma, sir, because there doesn't appear to be any back pressure changes because of the stone, sir. So, yes, sir, I would want to do a URS and a tumor partial nephrectomy, sir.
Bakshi sir, आपको opinion बोलो.
Yeah, the question is, suppose if you do URS in the upper moiety, Abhishek, then
yes,
what
sir.
are the chances that with the pressure that you are, water, saline pressure that you are going to apply, URS or RIRS, what are the chances of embolization of the tumor?
I'm not sure of that, sir.
Sure. Okay. So we had a discussion on that, and it was concluded that it is not, it will not happen. So you can safely go ahead with the ureteroscopy followed by partial nephrectomy. Okay. So
yes,
second, Dr. Bakshi will tell you what they have done it. So which one you will prefer, lab, robotic, open?
Sir, open only I will prefer, sir.
Okay.
So if you had facilities and if you had experience of MIS, in this patient, what would you do? Lab or robotic, whatever, but it would be retro or trans?
Retroperitoneoscopic, sir.
Why would you want retro?
Sir, I would not want to breach the peritoneum, sir. Because, sir, yes, sir, I would want to do a retroperitoneoscopy, sir.
So you would want to do a retro on all partials or select certain partials for retro? When would you do a trans or when would you do a retro?
Sir, less complicated masses, more on the posterior and Sir, I would want to go ahead with retroperitoscopic and sir, larger masses encroaching anteriorly. Sir, I would consider transperitoneal, sir.
Yes, and this patient, there was one more indication, strong indication for retro. He had a history of perforated appendicitis.
Yes, sir. Yes, sir. He had a previous history of appendicectomy.
Laparotomy, especially involving perforations of the GI tract, they are more likely to end up with bad additions. You would not, I mean, you can do a trans, but retro would be preferable. So that's why we did a retro on him. Next, please. Okay. We did this actually in our robotic urology conference. It was telecast live, and we did a retroperitoscopic robotic partial nephrectomy. DJ stents, we did not treat the stones we did put a couple of stents in both moieties. We did not do an actual URS, and patient was discharged on third POD, followed by URS and stone removal after 4 weeks. He is advised but you can do a URS as was discussed in that meeting and clear the stones at that particular sitting as well. Next, please. This was the specimen, and it was a renal cell clear cell RCC. Next, please. Okay.
Just answer.
Yes, sir. Yes, sir.
48-year-old man, 5 centimeter left renal cystic lesion, 5 by 3.5 centimeter Bosniak 4 cyst reported by the radiologist in the left kidney with enhancing solid components within the cyst. No comorbidities, just pain in the left flank.
Yes, sir.
The video. You can see the cyst to view on the left door. You can see the white solid components in the CT.
Yes, sir. This file
report.
Yeah.
You want to ask?
Yes, sir. So this again, I would characterize the. We can go for a. This appears it's a Bosniak 4, so it will require excision. We'll go for a partial nephrectomy.
So, what percentage of patients with Bosniak 4 will have malignancy?
So the incidence of malignancy is 92.7%. 92%. Yes.
Yeah, around 90%.
Yes,
okay.
Yes,
so partial nephrectomy, right?
Partial nephrectomy, yes, sir, because it's mainly exophytic. So we can attempt partial SOS radical nephrectomy.
We should attempt partial. Now approach
Yes,
what? Lab open robotic.
This patient, we can offer, sir, if expertise and experience is available, we can offer robotics, sir.
Yeah, we can. So, yes, there is a question. Retro lab. Yeah, we can do retro, trans, lab, robotic, open, whatever is, whatever you are comfortable with. But what special precautions will you take during surgery to prevent rupture and spillage? You don't want this. That is the main thing in a cystic RCC, right? You don't want the cyst to rupture. How would you ensure that?
So meticulous dissection to prevent a rupture of the cyst and no puncturing of the cyst. Take a wider margin if possible, and bag the specimen while removing it out.
Right. Handle gently and make sure the instruments are always into your view, whether you are doing lab or robotics, so no accidental puncture happens. And bag it properly before removal. This patient underwent a lab surgery. You can see the video. This was given to me by my friend, and I'll always be remaining grateful to him for this case because it's a good case. So while he was doing this, you can see there is a cyst rupture. The cyst has ruptured, blackish brown fluid oozing from the cyst, right? So he tries to turn it off, and you can see inside there are some necrotic material visible, right? So that was the brownish black tissue there. So what he did was he took a frozen section. You'll see it in a video very soon. Okay, he took a frozen section from the wall, which was benign. Okay.
Yes, sir.
I think we can skip the video because
Taking biopsy.
Yeah, so he took a harmonic scalpel and took a frozen, and the frozen was negative for malignancy. So what we did was just excise the cyst and the solid components. Okay.
Yes, sir.
So do you did the right thing? Do you think what would you do?
No, sir. So actually, this was from the cyst wall. So the solid component, the biopsy was not sent. That was not studied. So it could be fallacious. Yes, sir.
So the question is, would you do a frozen? Was he right or was he wrong? Would you do a frozen or no frozen?
So frozen, if has to be done, then it could. But this case, patient, it was bleeding and so actually, we would take it from the solid area if required, or otherwise not do a frozen.
So that is it required or is it required?
Not required, sir. Not required. Not required. Not required. It is Bosniak 4. Bosniak 4. It is not required. We'll go ahead with a partial nephrectomy. It is not required to do because incidence of malignancy is 92%. So we can justify the patient that the higher chances of malignancy, so surgery is justified.
So if you have ruptured the cyst, what would you do then? Would you open or would you continue with lap?
So we would open ideally to prevent more spillage, open it because it was bleeding also. So we'd either open it and complete the resection.
Okay, and the next question would be, if a rupture happens during spillage, are the oncological outcomes worse than what you would normally expect or not really?
So not sure about that.
Okay, so you should know. So actually, surprisingly, even if you rupture an RCC, there have been studies, meta-analysis, etc., but the oncological outcomes are at worse. So just 2% recurrences. I put the slide in the actual presentation. The incidence of recurrence is around 2 to 3%. So it's not that great, but it is definitely there. So we should try and avoid these kind of situations. Next slide. Okay, the final histology on IHC was RCC from the solid component, right?
Yes,
so
sir.
Now we have a situation where he has not completely removed the cyst and the solid component is showing RCC. Some cyst wall is still attached. Next, please. Someone did an FDG PET on this patient. Okay, it is showing a renal vein thrombus right up to the right into the IVC. We can have the report. Next slide, please. You can see the thrombus very clearly, and the report says that it is extending into the IVC for up to 3 centimeters. Okay, so this was missed on the CT IVP which was done.
Yes, sir.
Okay, next, please.
You will require open radical completion with external thrombus. Yes, sir.
Yeah, you do radical nephrectomy. Now the
level
question,
2 thrombus.
Because it's filled, would you want some adjuvant therapy, considering that this patient had a thrombus also and there was spillage? Would you give adjuvant or not?
So if there are no other nodes and everything are negative, and we will not give adjuvant therapy. We'll just completion nephrectomy with removal of the thrombus.
Correct. So adjuvant we don't give. There are only a couple of trials to suggest the benefit of adjuvant. One is the ASTRAC and second is the Pembro trial, keynote 1. But you are right. Unless there is metastasis, we don't. I mean, there are recent trials which show that there is some benefit of giving adjuvant in high risk. But right now in exams, I don't think we should be saying adjuvant treatment for high risk cases at this point. So no adjuvant. Yes. So next, please, sir. So what lessons we have learned? CT IVP is inadequate. So whenever you are handling a cystic tumor, always have a triphasic CT scan with you. Because this is a rare event. You don't usually get a renal vein thrombus, which is missed on a CT IVP, but sometimes you can get such surprises. So triphasic CT is the way to go if you are before surgery on any cystic mass, right? And minimally invasive, you can rupture it, but so as you said, low threshold for conversion to open surgery is needed whenever adverse situations. So next slide. Do we have time for?
Yeah.
Okay.
Yes,
Okay.
sir.
Yes, sir.
54-year-old female, hematuria before 7 days and a 10-centimeter right renal mass, heterogeneous with calcification, normal opposite kidney. Next, please. This is the CT. Okay, you clear cut large renal mass. Next, please. PET CT in these patients. T2, large mass. On a gross CT, there is no nodes or something. Would you do a PET CT
Not
in
PET,
any
sir, but CT test I will do, sir.
It's just okay. Radical nephrectomy. I think this is radical nephrectomy.
Open radical nephrectomy I will prefer, sir.
Okay. Would you remove the adrenal and the nodes in this?
Yes, sir.
Or
I
when-
will like to remove the this adrenal and lymph nodes with palpable drops, sir.
Sir,
So would
as per the recent guidelines, sir, unless there is any obvious involvement of the adrenal or there is involvement as per imaging, till then we don't remove the adrenal. Secondly, sir, lymphadenectomy does not confer any additional survival advantage. So, sir, both we will not do, sir.
If
Correct.
lymph nodes are palpable, sir, intra, then we can remove them.
Yeah, perfect. So this is the what the answer should be. And this is for minimal invasive. Is there a size cutoff which was discussed beyond which you would not want to do a MIS? I mean, the literature doesn't say that you should not do a minimal invasive surgery beyond a certain size.
10 centimeter, I think, is the
So,
cutoff.
so
for-
it should leave behind at least 20% of the remaining kidney. So more than 20%, other it will cause hyperfiltration injury. So at least 20% of the renal parenchyma should be left here.
No, we are talking about
It's for MIS versus open.
MIS.
So
and
I think 10 centimeter.
for minimal invasive, beyond which you would say that no, I will not do a lap or robotic. I would want to do a nephrectomy.
I think 10 centimeters is the cutoff limit, sir.
Oh.
Okay, so there, I mean, literature does suggest 10 or 12, but people do it for 14 or 15 also. But in exam, I think beyond 12, we should not, you would prefer open, right? Any other viewpoints, Dr. Mahendra, Dr. Gite, they would be.
Mahendra, you want to comment on the size?
No, sir. Actually, if on CT scan, normally as non-notice people are also doing a hybrid technique. Hybrid means the maximum part can be done with the laparoscopic, and only while mobilizing, other part can be done open.
What?
Hello.
Sorry. So, what is the advantage of doing a hybrid one? I mean, why would you want?
No, some people are doing so. It is only again depending on the expertise and the experience.
Yeah.
But if suppose that there is a colon is adhered to the mass and other thing, then definitely no point in doing MIS. And the size is not a criteria of not doing MIS for the critical effect.
Okay. So
if expertise are available and morphology is favoring for partial nephrectomy, size is not the criteria.
Okay, fine. So size is not a criteria for deciding MIS versus open. Correct. Anyway, this patient underwent a lab radical nephrectomy. Final histology showed upgradation to T3A. I think this we have already discussed. So this was regarding adjuvant. Next slide, please. Adjuvant therapy, no adjuvant therapy, this we have discussed. So I don't think we should be going into that. Next, please. Final case, 71-year-old hypertensive, hematuria, bilateral tumors. On the left side, there is 9/8/6. Right, there are two tumors. One is 7/5. Second is 2.5/2. A biopsy and it was a papillary RCC. Serum creatinine is 0.96. It is 71. These are the only two images we have right now. On the left side, you can see it's a large mass, 9 centimeter. Here, on the right side, most of the mass is exophytic. There is also on the right side, the other slide, you can see there is a small tumor, 2 centimeter, just above the norm, the large mass on the right side. So next slide, please. Bilateral tumors, what is your treatment option? I mean, in this patient, bilateral nephrectomy, would you want to do it staged or simultaneous? Or left nephrectomy followed by right nephron sparing, right nephron sparing by left nephrectomy, or medical therapy after the biopsy is showing papillary RCC to downstage and then do surgery?
Okay, Abhishek. Abhishek? Okay.
So staged surgery, left side first, followed by right
you
side.
answer. Danny, hold on. Bilateral, you will like to do bilateral nephrectomy?
No, sir.
Yes,
Stage
sir.
surgery.
Stage surgery,
No.
left side first, followed by right side.
So what you want to do? You want to do bilateral nephrectomy, or you want to do right-sided partial nephrectomy and left-sided nephrectomy? What do you want to do?
So left-sided radical nephrectomy, followed by later second stage right-sided partial.
Okay, so now first you want to do partial, or first you want to do radical nephrectomy?
First do radical because it is a larger tumor. The tumor burden is large, so that is we'll try to remove that first. So left-sided radical nephrectomy first.
Now, if you do left-sided radical nephrectomy, you are left with only one solitary kidney. Now, when you clamp and you remove the tumor, there are chances that patient will go into acute renal shutdown.
Yes, sir.
So first you want to do partial and then radical, or you want to do first radical and then partial?
So
Sir,
first radical
and then the partial.
First radical and then partial.
Yes, sir. Sir, in stone diseases, we do the better kidney first, but in malignancies,
No, but listen. If you do radical nephrectomy on the left side, now there is no kidney left when you are doing on the right side. So this patient may go into anuria and may require dialysis for some time. But if you do right partial, the left is already functioning. So after a few days, you don't have to wait much. After a few days, you do the left-sided nephrectomy.
Okay.
Yes.
Okay, you can go ahead.
Yes, so as Dr. Gaurang Bhai rightly said, we should be doing a right partial first, and always in your exams you should be speaking this because you take advantage of the function of the contralateral kidney. You don't want to dialyze him, which would happen if we do the other way around. And what we did, next slide please, sir. We did what you said, but which was not the right thing, right? There is a question whether we could then do this in the same sitting. I would not do it, but you can. If you want to do radical and partial at one sitting, you can. But in a 71-year-old man, I would not want to do it. So this patient underwent a left robotic first. Post-op recovery was uneventful. Discharge on 4th post-op day. Creatinine was 1.15 on 7th period. We did a robotic nephron sparing 3 weeks later. Warm ischemia time was 50 minutes. Patient required dialysis twice post-operatively. Next, please. This was the specimen of the right robotic. Anyway, next, please. Urine established from 5th POD on the right side after doing the right side. And his creatinine on discharge was 2.2, which was 1.9 at 6 months. Next, please. Now, after 20 months on a routine follow-up, he has got no symptoms. There is you can see on the CT, there is a 3 by 2.5 centimeter recurrent tumor in the mid-pole now. So recurrent 3 centimeter tumor mid-pole in the kidney, which is around 6 to 7 centimeters. Would you do a repartial? Would you do a radical? And how would you do it? Open. This was done robotically, but what would you do?
Hemang sir.
Yes, sir.
Is there any role of enucleation in such type of patient? Because patient had a bilateral multiple tumor.
And this was a papillary RCC, so yes, definitely. There is a role.
So here we can also offer ablative techniques because a recurrence and we want to preserve. So if ablative techniques are possible, then we can offer that in the form of high intensity frequency ultrasound or radio frequency ablation. If not available, then attempt the repartial nephrectomy. Approach would be open, sir, because a lot of adhesions from previous surgery. So
right, absolutely perfect. So that is what you would want. Next, please, sir. Okay, this was it. So this patient we have scheduled him for repartial. He has not come back yet. So Gaurang sir, can we stop here or you think we should continue?
Just ask them one question.
Okay. So there are 5 scenarios. 61-year-old man, you can see on the CT. 12 centimeter solid left renal mass with an 8 centimeter para-aortic nodal mass, you can see at the right. So it's a T2N1 disease. We did a left open radical nephrectomy with excision of para-aortic nodal mass and regional nodal excision. Next, please. So histology showed a renal cell carcinoma, clear cell RCC. Okay, now he comes with 1 year later retrocrural recurrences. You can see on the CT, one is 2 by 1.8 centimeter, another is 3 by 4 by 1.5 on either side of the superior mesenteric artery, on either side of the aorta. Okay, next please. Yeah, you can see the crus of the diaphragm here on both sides, and the recurrences are behind that crus. No other, we did a PET CT on him, nothing else. Next, please. What will you do? Surgery, medical therapy, or surgery followed by medical?
Medical therapy. Medical therapy.
Okay. 2 recurrences, young patient, nowhere else. So why not surgery?
So access will be difficult. Retrocrural might be difficult.
Access is difficult. But okay. Any other opinion? Okay, so I actually did operate on him, and you rightly said the access was difficult, but we expected this. So you have a generous chevron or midline incision. Okay, you can either approach the retrocrural area through the lesser sac, or you do as you do in RPLND, completely lift off the right colon, the root of the mesentery, lift it up, and we remove this. We could remove this, but it's difficult, yeah. So, but the treatment ideally should be surgery. So if you can't do it, you should be referring to a center where this can be done, right? So that should be the answer. I mean, your department may not do it, which is fine. But retrocrural recurrences, whether they are testicular tumor or renal cell carcinoma, if they are not metastatic anywhere, you can remove it. Surgery followed by medical therapy is controversial. Some people believe you can give sunitinib or any other medical therapy for 1 year. Some people believe that this is a R0 resection. You have completely removed all the disease, then you can wait, right? So the treatment should be surgery first. Next,
this is ideal indication for surgery as far as metastasis is concerned, except difficulty in approach.
Yes,
it is
exactly.
less
Right.
than 1 to 3 metastasis, and it is disease-free interval is near about 1 year or more.
1 year, yes, sir.
Yeah.
Okay, solitary kidney, 3 tumors, 43-year-old man. One.
So just pass. What you will like to do? Solitary kidney.
So open nephron sparing surgery, sir.
Fine.
Right. This was right.
Yeah.
Next is
Can you
right.
see? There are multiple stones. Left side also stone, right side stone, and left side there is a big mass. Okay. Yes, sir.
Yes.
What will you like to do?
So, sir,
Right sided multiple stones, left sided big mass.
so right-sided PCNL.
Okay.
And followed by the staged left nephrectomy.
Fine. That is one of the good answer. What they had done was little different. They have done, I think, they did a right-sided PCNL, left side they kept the this thing stand. Probably they thought that the stone may cause obstruction, and they wanted to wait. And then they did a left-sided nephrectomy. Okay. Now this is another case. Right renal stone with left renal mass. Abhishek, what would you like to do?
So the stone is 2.6 centimeters big, and the kidney function is 25% uptake on the DTPA.
Yes, Abhishek, you are there?
Yes, sir. Sir, I would want to do a right partial, right PCNL first, followed by left partial, sir.
Okay, fine.
Right digit stenting followed by left partial nephrectomy, then right PCNL.
No, you can go ahead. See, as we said, no, it doesn't take 48 hours, 72 hours. You can just go ahead and do the partial nephrectomy. 3 days are not going to make any difference.
Okay.
Okay. This is right renal mass T1A. What do you like to do?
Partial nephrectomy.
Okay,
So ideally, enucleation will be better.
It is 2 into 1.5 centimeter.
Would you offer active surveillance because it's very small, or would you want?
If the patient is ready for the follow-ups, then we
patient-
can offer the patient active surveillance. Otherwise, enucleation would be the best option.
If the patient is not willing for any kind of management, sir, then we would offer for active surveillance with the consent of the patient that if the renal mass shows any untoward changes, we'd go ahead and have to manage. We'd go ahead
Abhishek, what is the rate of increase in size?
Sir, the rate of increase in size should be
0.35 mm per year, sir.
Yes.
0.5 mm per year, I think, sir.
0.35, right?
3.5 per year.
Okay.
So how many years it will take to become 3 centimeter or 4 centimeter?
It's 10 years.
Shake around.
10 years. And it is 3.5 centimeter. Actually,
So in 3 years, 3
4
centimeter.
to 3 years.
3 years it will be, and another 3.
You can always observe, na? Active surveillance if he is willing.
But if he is fit, sir, for surgery, it is enhancing mass, sir. So based on the complexity and characterization.
Mahendra, what is your say?
Yes, sir.
Or Dr. Ganesh, he is there?
No, Ganesh has left, I think.
Mahendra, what do you say?
I agree, sir. Whatever you said, and Abhishek also said rightly, we have to very small mass, and the growth rate is 0.1 to 0.35 centimeter per year. So again, we have to counsel the patient, and depending upon his anxiety and the compliance and acceptability, we have to treat. Because if we do this case minimally invasive technique, it's difficult to localize the mass also. This is a small mass. We need intraop sonography for these cases.
Okay.
So both the approaches are acceptable, provided patient understands and accept the counseling. And at present, sir may ask what is the role of RFA.
Fine. So, Bakshi, what is your say? Final.
Yeah, so we can, I would prefer to operate, but active surveillance is also an option, which I would explain to him. Right.
So that is what I have told him.
Okay.
I think that was.
Yeah.
Yes, Hemang, thank you very much. I think we have covered almost all different scenario, and when this will go on YouTube, many even other consultants, they will be happy to look at it.
It was a pleasure. Everyone.
Hemang, for joining the show.
I loved it. So we had a good time at the UCCon also, West Zone and we had a good time here. So we learn from each other. It is always nice.
Yes, sir.
And I think students also answered quite well. They are
Yeah, very well
their
prepared.
approach and thinking is reasonably good.
Yeah,
Thank you, sir.
I'm sure they will have good performance in their exams. I wish them all the best.
Thank you, sir. Thank you, sir.
Hemang
You
Bakshi, sir. Hemang sir.
Yes, Mahendra, you are saying something.
I want to ask one question to Hemang sir. Sir, is there
Yes.
any left? Hello.
Yeah.
Mahendra, your voice is
Can you
little
speak
low.
loudly?
Yeah. Sir, can you hear me now?
Yeah.
And so, sir, my question is this: out of these often 4 or 5 cases NSS,
Yeah.
you how do you select the case laparoscopic and robotic surgery? The first case, it was slightly technically difficult, which can be done easily with robotic, but
Yeah.
you did laparoscopically. So how
So,
did you select?
So good question. My preference is always robotic as far as possible because it's easier. I would say it is a little better, certainly as compared to open and lap, and it is borne by literature also. But I would do laparoscopy for only one indication, and that is the patient cannot afford robotics. Okay, so that is not an exam question. So if you ask me, my indication for doing lap would be the patient doesn't have money for robotics, I would do lap on him. Otherwise, I would prefer robotic.
Yeah, something that was in my mind. I want to confirm it from you only.
Okay.
Yeah,
so,
yeah.
That may be the only cause why to select the laparoscopic when we have robot.
Yeah, absolutely. Because if you see the meta-analysis of more than 4,000 patients, with comparing lap versus robotic, it was published by Dr. From Singapore. I forget the name. But it clearly says more than 4,500 patients, all parameters like warm ischemia time, blood loss, everything was recovery of renal function, everything was better with robotic as compared to lap. So these two techniques have been compared and robotic has been found to be superior. So there is no doubt about that. I mean, there would be exceptions, like some expert surgeons would do the lap as good as a robotic. But if you compare in general, robotic would score over lap any day because the instruments are flexible, the magnification is better. So any day, the ergonomics is better. Any day I would prefer robotic over lap. And there is literature to back it up. So
Gaurang Shah, sir.
Yeah.
Sir, one thing, only 2 things I want to say after this class. First of all, this the level of students has improved a lot. I observed that nowadays we just have to give them a finishing touch about the history and approaches. So congratulate to all of you for this classes. And second thing about the OJAS. OJAS, can you hear me?
Yes, sir. Yes, sir. Yes, sir.
This is for everybody. In your case, you used one line.
Okay,
You used the availability of expertise and experience. Okay.
Okay. Yes, sir.
This is not available anywhere. This is inside you.
Yes, sir.
So avoid this availability of facilities, not the expertise and the experience. Okay.
Okay. Yes, sir.
Avoid using these lines because examiner may just held you in these lines. Be careful.
Oh, yes, sir.
Thank you,
Yes,
sir.
sir.
Thank you,
I
Mahendra.
think
Thank you, sir.
by pointing out these lines.
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir.
Okay. Thank you, Pankaj.
Thank you, Hemang sir. Thank you, Gaurang Shah
Gite
sir.
sir,
Thank you,
and
Gite sir.
all the
Thank you,
students.
Maheshwari sir.
Thank you so much. Thank you, sir.
Thank you, Mahendra sir.
thank you, Gaurang bhai. It was
Thank
nice.
you.
Hello,
Good night,
Hemang.
Hemang sir.
Thank
Good
you
night,
very
Gaurang sir.
much.
Good night, Gite sir.
Thank
Good night, Pankaj sir. Yeah.